Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 193rd episode of the CodeCast podcast today. My name is Terry Fletcher. So it is the last Tuesday of the month. We actually had 5 Tuesdays this month, so June was a long month, even though it only has 30 days in it. It felt like a long month to me. And so that means that we're going to have a Top 10 Tuesday, and today I'm going to talk to you about the top 10 mistakes coders can make when coding for ICD-10-CM. So I actually found this as part of an article in the AAPC Business Monthly magazine. It was in an article by Dr. Stacy Chaplain, MD, CPC. And so I also thought I'd add my 2 cents in, as it was perfect as we're heading into the summer where things slow down a bit. And so you have some time to really focus on accuracy when coding. And I'd like to see everybody really try and do that. And so this is just some interesting information I thought when I found it. So let's go ahead and jump right in. So I'm going to start from the bottom up. So number 10, coding straight from the index drives me crazy. It's kind of like in CPT, coding from the header of a report. You need to read the notes in the tabular list to make sure that your selection is correct. If you code only from the index, you will miss extra digits, you'll miss notations, you'll miss so much information on what the most accurate code is, and also directions on if this isn't a part of the language of the code, it directs you where to go. So coding straight from the index, that can be a problem and a mistake. Number 9, this is big, sequencing codes inappropriately. You want to code the underlying disease before the manifestation, the injury before the E code. So making sure that you're coding correctly from a sequencing standpoint, especially if you're using modifiers. If you're using a 25 modifier on an E&M and then another test or procedure on the same date, even though the 25 modifier says that you don't need to have different diagnoses, try talking to a biller. It's really hard to explain that significant separate service if you don't. Or think about if you're GI practice and you are in different parts of the colon doing different techniques for a colonoscopy. You would need to have a separate diagnosis for that. If you are trying to code for heart disease with renal failure or heart disease without the physician specifying if there's kidney involvement, you have to know those things before you code your services. So sequencing codes inappropriately is definitely a problem. Number 8, assigning too few codes. If an underlying condition is a factor in today's treatment, you need to sequence it as a secondary diagnosis. You know, if a patient, and one of the biggest things is social determinants of health. Please do not leave those out. They're making such a difference when it comes to not only tracking, but statistical information. I mentioned a couple weeks ago on the podcast about not having enough physicians when patients were admitted to the hospital using the homelessness, SDOH. And so we didn't know how many of the COVID patients were from homeless situations. And I was wondering why there wasn't an uptick there. So too few codes. If you've got a patient that is a previous smoker and, they're there with COPD, but it doesn't even refer to that, that again can be a problem. So assigning too few codes can be detrimental to the overall risk on that patient. Now, in saying that, number 7 is assigning too many codes. If a chronic condition isn't part of today's treatment or care plan, then it's really hard to justify the coding of it, and it doesn't need to be reported. And so it should be documented once a year in like a wellness visit or, things like that, because you need to have it for risk adjustment purposes. But remember, risk adjustment documentation is about active problems. So it's just something that you have to, what are you treating today? And then not looking beyond your coding book guidelines. You want to make sure you're checking for annual updates to the ICD-10 official guidelines for coding and reporting. They used to only update it once a year, then it was once a quarter, and now you have to look at not only the ICD-10, the AHA, World Health, CDC. They're putting things in there now that they're because of emergency situations. They want to be able to have things reported for statistical information in real time. So make sure that you're not just looking at a book that you ordered the previous year. Make sure you're looking at websites and you're going to those authoritative references to make sure you get the latest updates. Coding for rule-out diagnoses, number 5. For professional claims, when we mean physician claims, if a test result is negative, do not code the suspected diagnosis to justify the test. So symptom codes get the doctor paid without compromising the medical history of the patient and trying to code it to the level of specificity that it hasn't reached yet. Now, I hate keep bringing up COVID. I'm COVID fatigued too, you guys. But just letting you know, there are some different nuances with COVID on suspecting situations, so you need to look those up. But for the most part, as far as regular professional claim rules, make sure you code what you know and not what you don't. Number 4 is truncating codes. Make sure that if a condition provides details in 4th or 5th digits, that you're using them. So a truncated code is an invalid code, and the quickest way to get a denial. That means you have not added enough digits. You only looked it up straight from the index, and you didn't get that, 4th, 5th, 6th, or even 7th digit, or even placeholder digit to make it an appropriate code. Number 3 is settling for a code that is vaguely appropriate. So don't settle for other and unspecified or other specified unless you've exhausted all other possibilities. So it just calls for lazy coding. I see still when codes call for laterality, right and left side of the body, a lot of offices will still do unspecified. If you don't know where that knee pain is, then somebody's not paying attention. And I really believe that it's important because remember, whoever submitted for x-rays, whoever is submitted for the facility payment, they know what side of the body things are on. So it's really important to make sure when laterality is needed, when specificity is needed for a specific area, then that you use that. Or if it says with or without bleeding, with or without hemorrhage, things like that. There should be documentation that supports those details so that you're not settling for a code that, again, is just vaguely appropriate. And that's number 3. And then number 2 is letting time get away from you. So make sure the code sets and guidelines you're using are those that are appropriate for the data service on the claim. One of the things that when I was teaching a session for the NSCHBC conference, yearly conference a couple weeks ago, one of the things I brought up in my session was how I see so many offices saying, well, I don't have time to do that. You need to make time to be accurate. So take a breath, slow it down if you have to. Even for those of you that have certain quotas you have to reach, coding is not just and I don't mean to discount receptional positions, but it's not just a job you come in and do and you leave. It's something that we get certified for, that we get credentialed for, and that we train on and have to get, additional CEUs for to keep up our skills. And so make sure that you are using current information. Also, just in saying that, I would really encourage any administrators, office managers, any supervisors that aren't coders to try and take a course on it, to try to know what your staff is doing. I'm seeing that a lot of staff are starting to move on and do different things or work for different companies, and they're kind of leaving their other jobs that, without any personnel. And so I'm getting a lot of administrators and managers reaching out to me saying, I don't know how to do this. I'm not a coder. Well, if you're in a supervisory position that includes coders, you need to have at least a point of reference. You need to make sure that you understand at least the guidelines on coding. Otherwise, how can you manage, your staff if you don't at least have a point of reference? So try to take a class, at least listen in. You'll absorb some of it. You may not be a coder when you're done with that class or that session or that webinar, but you definitely at least will have a point of reference. And that's really what we need our supervisors and our managers and administrators to have. And then number 1, and I like this, the way the physician put this, thinking ICD-10-CM codes aren't money codes. If the codes are old, denial. If the codes are truncated, denial. And if the wrong codes are assigned or sequencing is wrong, denial, denial, denial. So denials cost money. You have to go find the code. You have to make sure it's coded appropriately. You have to find out why it was coded the way it was to start. Filling out either a reconsideration form for a rebill or for an appeal, or a corrected claim if the wrong diagnosis code was submitted at all. And what I find sometimes, which is kind of scary, is not only was the wrong diagnosis code submitted, but the patient didn't even have the condition. So now you've labeled a patient with something they never had, and that can be a real problem, not only for the code or the reimbursement, but for the patient in the future. So make sure that you're keeping these things in mind. And again, coding straight from the index, don't do it. Sequencing codes inappropriately, assigning too few codes, assigning too many codes, not looking beyond your codebook guidelines, coding rule-out diagnoses instead of coding what you have, truncating codes, not including enough digits, settling for a code that's vaguely appropriate, letting time get away from you and not knowing what's the current codebook to have, and then thinking ICD-10-CM codes aren't money codes. They are part of your key to reimbursement, along with linking that to your appropriate service CPT code. And that's what's going to make you an invaluable employee, to make sure that you're clear on that information. Okay, so even though we've been talking about coding, let's talk about a coding question. So your provider or physician documents that a patient has chronic lower back pain due to surgery or trauma. So how do you code for this? Well, you need to pay careful attention to your doctor's documentation, especially the word chronic. That will guide you outside of the M54 codes to code from the G codes, G89.2 for chronic pain codes. That's a classified group. So you could pick possibly from G89.21, that's chronic pain due to trauma, for chronic pain, back pain due to trauma. G89.28, other chronic post-procedural pain, that would be for chronic back pain due to surgery, or possibly G89.22, that's chronic post-thoracotomy pain for chronic back pain due to thoracotomy, a surgery where a surgeon makes an incision between two ribs to gain access to organs such as the lungs that are located in the chest cavity or thorax. So it's very specific when your physician starts saying the word chronic. It takes you out of the regular, dorsalgia or low back pain codes in the M54 and the 0.5 and the M54.9 scenarios. So just know that if your physician says chronic and why, then it's going to take you out of that code series. So be aware of that. Our coding question today is brought to you by Do, the nation's #1 retirement app, Forbes' top-rated finance blog, Do.com. That is DUE.com. We love money. Okay, so everyone, my personal tidbit this week, I'm very, very happy I got a vacation. Napa was just, it was so wonderful. We had perfect weather, perfect group of friends with us. Didn't drink too much. I just did enough to where I just feel like it was just a great time. So if you can get out in nature and just really breathe in the fresh air. We didn't have to wear a mask. Everyone in our group was vaccinated. So it was just a great, great time. So I'm hoping that I get another one in the fall, not necessarily to Napa, but hopefully another vacation. But I think these vacation ideas are really good ideas. So that's it for me, folks. Make it a great day, and I'll talk to you next week on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.